Hi everyone, my name is Buzzy Bittinger, and my evaluation project is called Continued Care for Non-Accidental Traumatic Brain Injuries in Children. So the focus of this evaluation was on pediatric traumatic brain injuries and the continuation of care. For this evaluation, I worked with patients seen at the Non-Accidental Traumatic Brain Injury, NATBI, clinic at Nationwide Children's Hospital. Children are seen at this clinic once every 7 months from the time of injury to the time they are 5 years old. This was a program-level evaluation with Child Protective Services, CPS, as the intervention. 30 cases were reviewed to determine if children with a TBI diagnosis are more likely to continue care in CPS custody or in custody of their parents, who could potentially be their perpetrators. CPS was the intervention for this evaluation. Though there are numerous problems with the system, my hypothesis for this evaluation was that children in CPS custody would be more likely to continue care for their TBI than children rehomed with their parents. I believe this to be the case because most patients in this clinic were likely abused by one of their family members. Parents can also become very overwhelmed with the various medical appointments to treat a TBI and can possibly be embarrassed to seek treatment due to the negative stigma and assumptions about the cause of injury. My goals were to increase the awareness on child placement and how it affects treatment by sharing my findings with the medical team within the NATBI clinic. I measured these outcomes by seeing if patients were coming to clinic and going to their follow-up appointments regularly. If so, were they in custody of CPS or their parents? If they are placed with their parents, were their parents suspected perpetrators? I hope my findings can educate caregivers on the importance of this clinic and how the environment in which a child is put into affects their safety and well-being. I anticipated that my results would show that children within NATBI are more likely to receive care if they are not placed back with their potential perpetrators. I hope that my results will inspire people to really consider child placement to ensure the safety and well-being of these children. For my measurement plan, I sorted through patients' charts in Epic at Nationwide Children's Hospital. I randomly chose 30 patients seen in clinic from 2019. Of those 30, 10 are in CPS custody, 16 are in familial custody, and 4 have been adopted. This was an existing measure because I simply derived the information that was already in the charts. I reviewed charts, determined if the patients were in custody of CPS or family, and then sorted through their various appointment dates to see if they showed up. This measure should be highly reliable because patient information is constantly being updated in the charts to ensure accuracy. This measure should be valid as well because the information will compare the two groups to determine who is coming to appointments, therefore determining who is more likely to continue care for their TBI. This should be considered face validity, as I did not measure the reasoning behind which group is more likely to continue care. For this program evaluation, I conducted a quasi-experimental comparison group design to compare patients in custody of CPS versus patients rehomed to their family post-injury to determine which group is more likely to continue treatment for their TBI. I had access to the patient's charts in Epic, which is how I derived the data to complete this evaluation. This evaluation did not cause any human subject issues or ethical concerns. Patient names are anonymous, and their stories will remain confidential in order to respect privacy and prevent HIPAA violations. I have selected a quasi-experimental, post-only comparison group design, as this allowed me to examine the differences between the control group and the treatment group. This type of design lacks randomization because participants were not randomly assigned to the identified groups. This was appropriate for this evaluation because although patients were randomly selected, they were not randomly assigned to CPS versus their family. This design allowed me to compare outcomes between the treatment group, CPS, and the control group, family. Normally, this design suffers from weak internal validity because there's no way to determine if groups were similar to begin with. In this case, all of the patients have a TBI diagnosis. Therefore, they are similar whether they are in CPS group versus familial group. My data analysis shows that in the year 2019, 40% of the CPS group missed or rescheduled an appointment, 50% of the familial group missed or rescheduled, and 50% of the adoptive group missed or rescheduled. In total, 10% no-showed or no-contacted. Of that 10%, the patients that missed were from the familial or adoptive care. All CPS patients either showed up to appointments or rescheduled missed appointments and followed through. This bar graph further displays the results previously mentioned. In other words, 60% of the CPS group showed up to appointments on their scheduled dates, whereas only 50% of the family and adoptive group showed up to appointments on their scheduled dates. The outcomes of this evaluation show that although there are flaws in the system, children placed in CPS custody are more likely to seek TBI treatment than children placed back with their families. This could be the case because most patients in the NATBI clinic were likely abused by one of their family members. Parents can also become very overwhelmed with the various medical appointments to treat a TBI and can possibly be embarrassed to seek treatment due to the negative stigma and assumptions about the cause of injury. The strengths of this evaluation were that pre-existing data was accurate and updated. Deriving the data was simple, as the only requirement was to sort through charts to determine who came to appointments. Data might have showed more significance if the groups were all equal in numbers. The patients were chosen randomly, but were not assigned to the treatment or control group randomly because they were already placed. This evaluation needed to be a post-test only comparison group design because each patient is at a different level in treatment. There was no plausible way to set a pre-intervention. The goals of these findings are to educate people on the importance of child placement post-injury to ensure safety and follow-up care for their TBI. Children with a TBI diagnosis need several forms of therapy depending on the severity of the injury. In general, family-centered practice is the foundation of intervention for pediatric TBI. Caregivers and family members are likely to be impacted by a child's TBI as well, and they play a vital role in treatment outcomes. Additionally, the family environment post-injury impacts a child's functional outcome. Family-centered practice can improve a family's adaptability to changes brought on by a TBI by helping family members openly communicate, identify priorities, and learn how to problem solve together. If children are to be placed back with family, are they safe? Do families have adequate resources to adhere to treatment? If families choose to drop out of the clinic, why? And how can the treatment team provide families with resources and education to bring their children to the clinic? It is imperative that these children get the appropriate treatment, especially for significant TBI diagnosis. Whether they are placed with CPS or rehomed to their families, caregivers need to be provided accurate education and resources to give these children a fighting chance at the life they deserve. Thank you all so much for watching this presentation. I hope you found this information interesting and valuable. Please take care of yourselves during this crazy time. Stay home and wash your hands.